So now let's look at the heart rate, now that you know how important it is. When we're looking at that computer screen, we are deciding, first of all, what is our baseline? Where is our fetal heart rate the majority of the time? Next, we're looking at variability. We're going to talk about how significant that is. Last, you are looking for changes, alterations in the fetal heart rate, whether it is an alteration of its short increase, an acceleration, or a deceleration. Decelerations happen in different patterns. We're going to talk about how you can tell which is which. You have early decels, late decelerations, variable decelerations, and prolonged decelerations. Do not confuse variable decelerations with the concept of variability. These are two separate things. This is going to be more clear as we continue to talk. Here's a nice picture of a fetal heart rate tracing. First thing I'm going to do is figure out my baseline. This is a little challenging with this fetus. You can see this kiddo's probably very active. Our heart rate is all over the place. We like to see this. That's a good thing. Our central nervous system is able to regulate that fetal heart rate every single second so it can adapt to its environment as needed. This tells us our central nervous system is being well oxygenated. So in slang terms, on the floor, I would call this a very happy baby. We're happy to see. If I'm looking for my baseline, I'm looking for where my fetal heart rate is the majority of the time. You need a 10-minute tracing at least to pick up a good baseline. 3, 4, 5, 6, 7, 8. You can see most of the tracings that we're going to see in computer slides are 8 minutes. We're going to assume this is the full 10, and I'm going to say my fetal heart rate baseline looks to me to be about 130. Note the numbers: 120, 150, 180, 90, 60, 30. Dark red lines are 1 minute apart. The little tiny boxes are 10 seconds. So you've got 10, 20, 30, 40, 50, 60. If I'm looking at my contractions, beginning of 1, 1, 2 to the beginning of the next, I have these contractions are 2 minutes apart. 1, 2, 3, and I still don't see a contraction. So I know my contractions are probably 2 to maybe 4 to 5 minutes apart. You can say a range, that's okay. My baseline is 130, my contractions 2 to 5 minutes apart. The next thing I'm looking for would be my variability and then my periodic changes. We'll discuss those in just a bit. First though, let's talk about your baseline. This information must be memorized and put in your head. Your normal baseline for a fetus is from 110 to 160. The good news is that is also a normal baseline for a newborn, so you don't have to memorize two different numbers. Just like an adult, if we have a heart rate that is faster than normal, we call it tachycardia. If we have a heart rate that is slower than normal, we call it bradycardia. Remember, a baseline must be at least 10 minutes. So we cannot say tachycardia or bradycardia until that fetal heart rate baseline has been there for 10 minutes or greater. This is an example of what bradycardia would look like on a fetal heart rate monitor. Here I have about 80, and then I seem to drop even further. This is not a good day. Down to 60 beats per minute. That's a pretty significant difference from 110 to 160. So assuming this is a full 10 minutes, I would have a fetal bradycardia. Look at my contractions. Look at my heart rate. In this scenario, I know that my fetus is not being perfused adequately. So I'm going to need to do some interventions to change that very quickly. This is an example of fetal tachycardia. 180 is my baseline. That's where my baby hangs out the majority of the time. My contractions are about every 1, 1, 2, 1, 1, 2, about every 1.5 to 2 minutes, coming very frequently. Fetal tachycardia is not as immediately concerning as fetal bradycardia might be. We got a little bit more time to evaluate, but you do need to remember that the most common cause of fetal tachycardia is maternal infection. Frequently, your fetus's heart rate will increase before your maternal temperature increases. The first intervention you would do for this baby, check your mom's temp. Once I have established my baseline, I'm looking at variability. Variability is basically the squiggliness, the beat to beat to beat change of that fetal heart rate. What variability tells us specifically is how the sympathetic and parasympathetic nervous systems are reacting, the push and the pull effect. If I have a beat to beat to beat to beat change, I know that push-pull effect is working well. My baby can adapt to its environment. If I do not have any change, if I have a straight line, that is a bad sign that my central nervous system is being impacted and is lacking oxygenation. This means that variability is the best indicator of fetal well-being. I want you to stamp that into your brain. Variability is the best indicator of fetal well-being. So of all of the information that we're looking at on this monitor, variability will give us the best information that we need to make changes in the plan of care. This is an example of some variability. See the squiggly line? Beat to beat to beat to beat change. This is a big change in the baseline. We call that an acceleration. Variability is that beat to beat to beat to beat little change in the squiggliness of the line. This is a good example of what different types of variability would look like so you can compare. Straight line, absent. This is bad. I would be intervening quickly here. Minimal variability. You can see a little squiggliness. There's not a whole lot. If you want to get technical, it's a 1 to 5 beat to beat change. You don't need to memorize that number, but you do need to just give a general estimate. Minimal variability can be caused by hypoxia. However, it can also be caused by narcotic medications, by magnesium sulfate medications, or even something as simple as my baby is asleep. If my baby is sleeping, it makes sense that they're not going to have a lot of changes in their heart rate, just like you and I when calm down. Babies tend to sleep in 20 to 30-minute sleep cycles. So we can be patient and we can watch minimal variability for 20 to 30 minutes before we start to get concerned and intervene. Moderate variability is a beat-to-beat change of roughly 6 to 25 beats per second. It says per minute, but really it's that squiggly line. This is where we would like to live. Most well-oxygenated babies are going to have moderate variability. Even if they're having some decelerations, moderate variability is proving to me that that central nervous system is working well. Marked variability is less common. I have it on here so you'll recognize it if you hear it referred to in your clinical experiences. We don't really know what marked variability means. It could be good, it could be bad. This makes it a little bit more challenging. We know our central nervous system seems to be working, but sometimes we think marked variability might happen because some type of stress to the baby. We're not sure either way. So in that scenario, I might do some things to enhance my uteral placental perfusion, make sure my baby's getting all the oxygen that my baby needs, and continue to monitor. So we've established our baseline. We've looked at our variability. Now we're going to assess periodic changes in the heart rate. The first change we're going to talk about is accelerations. We saw an example of that on the slide I showed you with variability. Accelerations are transient increases above your baseline. They have to be at least 15 seconds long from beginning to end. They have to go up by at least 15 beats from your baseline. That's a good way to tell the difference from normal variability. You can see accelerations are a little bit longer lasting, bigger changes. They can happen in response to fetal movement. They can happen with contractions. Picture what your heart rate would do right now if you jumped up, ran around the room for 30 seconds, and sat back down. Your heart rate would increase. Your brain would say, hey, I need some more oxygen for these muscles. When you sat back down, things would go back to normal. Your brain would say, okay, we're good. We can go back to where we were before. If I have a fetal heart rate that can have an acceleration, I have definitive proof that my central nervous system is working well. So accelerations are very positive. I like to see them. This is another example of acceleration. Acceleration. Barely is probably more than 10 beat increase instead of 15. So we can't get away with calling that an acceleration. But here I have two good accelerations in a less than 10-minute period. That is a very reassuring sign I have a well-oxygenated baby. Here I can see beat to beat variability. I've got moderate variability here. I have moderate variability here. Long ago, we called variability long-term or short-term. You don't need to worry about this term anymore. We changed up our terminology. Now it is simply variability, so don't let that long-term throw you. Contractions down here, 1, 2.5, 1, 2. 2 to 2.5 minutes, lasting a good 60, 70, 80, 60 to 80 seconds long. Let's talk about decelerations. Early decelerations are the first of the categories we're going to talk about. The good news is that early decelerations, we think, are caused by simply head compression. Think about the labor process. What does that fetal body have to do to go through that tiny opening and be born? There is some head compression involved in that. We expect it. It does not concern us. So early decelerations simply mean our fetus is descending, and that's not a bad thing. They are not related to a lack of oxygen. This makes them benign. They're not associated with hypoxia or acidosis. Early decelerations begin at the beginning of the contraction. They're at their lowest point at the peak of the contraction, and they have returned to baseline before the contraction ends. They usually look fairly uniform in shape or similar to each other. Here's a good example. Here's the peak of my contraction. Here's the very beginning of my contraction. You can see starts to go down. So I want you to picture in your head that uterus is starting to squeeze, starting to get tight. As the uterus squeezes that head, my fetal heart rate decreases. As the contraction goes away and the pressure on that head releases, my heart rate increases. Here's a little bit more of a significant early decel, easier to see. Here's the beginning of my contraction. Here's the peak at the lowest point. This contraction doesn't go all the way back down until here. And by the end of that contraction, my fetal heart rate is back up to the baseline. This is how I can tell this is an early deceleration. Because I expect it, because it's normal, I do not have to intervene. In class, we'll talk about a few unique situations where we might look at a little bit more closely. Variable decelerations are your second type of decel. Variable decelerations are called variable because they vary in shape. They can look like a U, they can look like a V, they can look like a W. They may happen with a contraction. They can also happen without a contraction. What they do have in common is a sudden decrease and a sudden increase in rate, which gives them their unique U, V, or W shape. They can be different in timing, different in depth. What they have in common again, we know what causes variables, decelerations. That is cord compression. So something in there is squeezing our umbilical cord, causing a sudden drop. When that cord is released, it is a sudden return to baseline. Lots of things can cause cord compression. It might be the contraction itself. It might simply be fetal movement. Babies are known to reach out and grab their cords and squeeze. Different things can do that. This is related to a decrease in oxygen, so I need to intervene and do something to change it. What is the least invasive, most effective thing I can do to release cord compression? Change my mother's position. If she's sitting up, I'll lay her down on the side. If she's laying down on one side, I'll flip her to the other side. I want to shift that fetus around in there to try and get the weight off the cord. Once I have done that, I might do a vaginal exam. I am checking her cervix to see if there has been a sudden increase in cervical dilation, or to make sure that my umbilical cord didn't slip out into the vagina ahead of my baby. If that had happened, think that that head would come down and cause a constant pressure, which would cause a long variable deceleration. Other things that I can do, if I have any kind of medication making my contractions stronger, I'm going to stop that because my fetus is not tolerating those stronger contractions. I might also want to use an amnio infusion. We're going to talk about what that is. Once I have done my interventions, then I'm going to notify my MD. This is an important fact to keep in mind when we're talking about interventions for fetal heart rate monitoring. Picture the phone call to that doc or the midwife. You're calling your provider to say, hey, I see potential fetal distress as evidenced by variable decelerations on the monitor. What's the next thing that your provider is going to ask you? What have you done to fix it? You're not going to let your baby lack oxygen while you're updating your provider until you've tried to change their position, until you've done a vaginal exam, until you've done whatever you can to enhance uterine perfusion. Then you can call your provider and say, hey, this happened, I did this and it worked. Or this happened, I did this and I am still concerned and I need further information from you. One of the things that your provider might be able to do to help is to authorize an amnio infusion. This is a specific technique usually used for variable decelerations. If cord compression is the cause of a variable deceleration, decreasing the cord compression is going to make that better. An IUPC, remember that term, intrauterine pressure catheter, has to be in place in order for an amnio infusion to be done. So if your patient doesn't have an IUPC, your provider is going to have to come in and place this in order for it to happen. Once the IUPC is in place, there's a little, I'll show you in class, a little IV port on that IUPC that you can attach to tubing and normal saline, hopefully warm normal saline. Unless you want to wake your baby up, then room temperature will be okay. You're going to put extra fluid through that IUPC into the uterus itself, replacing some cushion that went away when your patient's water broke. As we put more fluid into that uterus, it's going to create a cushion around that umbilical cord, which is going to take the compression away, which will hopefully fix our variable decelerations, so she can continue through the labor process. Now think, we have to have an IUPC in place to do this, which means her water has to be broken. If someone's water has broken, they're in the labor process. So I'm only going to do an amnio infusion if my patient is in labor and giving birth. If I had a patient come in who was preterm, I didn't want to deliver her baby yet, and she was having variable decels, this would not be an option unless I decided we're going to deliver this baby early. So an amnio infusion is only used in the labor process. Let's show you what some variable decelerations look like. Note the sudden decrease, the sudden increase. There's a nice V shape. I have a baseline of 150. I have moderate variability, which is the best indicator of fetal well-being. So while I have concern in that my baby has some cord compression, I know overall my central nervous system is working well. This variable deceleration seems to happen with the contraction. This one is a little deeper, but there's no contraction there. Cord compression caused by something else. As well as over here, you can see this baby sailed through this contraction and then had a little variable here. If I go in and change my mom's position, maybe I'm going to shift that baby so they quit squeezing their own cord, or I get whatever pressure is on that umbilical cord off of it. This is an example of something that's a little bit more severe. I want to caution you here, we are trying to remove the term mild and severe from our descriptive categories because they're very subjective. What's mild to you may not be mild to you. However, this is an older slide, so for the purposes of letting you see what variable decelerations look like, we're going to show this here. Again, they are different from each other, but they do have a sudden drop and a sudden return. Last, let's talk about late decelerations. Oh, sorry, second to last, we got two more. A late deceleration is probably the most ominous sign that we have. Late decelerations are caused by uteral placental insufficiency. My uterus and my placenta are not exchanging oxygen adequately. There's something that needs to be fixed there. These are going to look different from the other two described decelerations. They're delayed. The decrease happens after the contraction starts. It returns to baseline late after the contraction ends. It's a late recovery, which is why they're called late decelerations. I want to intervene. If I see a late, I need to fix that uteral placental perfusion. How do I do that? Once again, our first intervention is changing her position, but for a different reason. I'm also going to stop any medications that are making my contractions stronger. I'm going to put some oxygen on mom, because the more oxygen mom has, the better our uteroplacental perfusion is going to be. Oxygen in L&D is always 10 liters rebreather mask. Nasal cannula does not get oxygen to the fetus. It's got to be an oxygen mask, and it's always 10 liters. Another thing I might want to do to enhance my perfusion is give my patient an IV fluid bolus. You're going to see a lot of fluid given in labor and delivery. That extra fluid is going to go into my vasculature system and enhance my circulation. If I have a volume issue, it's going to increase my volume, which is going to improve the circulation, which is going to get more oxygen to my uterus. Once I have done my interventions, I'm going to notify my provider, and if the problem continues and my variability is not reassuring, I'm going to anticipate an expedient delivery, which might mean a C-section. But if my patient's very close to a vaginal delivery, maybe it means we use a vacuum or forceps to try and get that baby out a little more quickly. So why, you ask, is our first intervention turning her to her side? Because the most common reason for late decelerations, the most common reason for decreased perfusion to the placenta, is simply that my baby's weight in the uterus is pressing down on my maternal aorta and vena cava. Look at the compression here. I don't have as much blood going out to my mom's circulatory system, so my uterus is not going to be well perfused. If I simply shift my mom off to one side, I displace that weight, and look at what happens to my maternal aorta and vena cava. I have significantly increased my perfusion simply by tilting my mom off her back, thus saving me all of those other more invasive interventions that I might make if the problem continued. If I was changing her position for a variable deceleration, I would be trying to relieve cord compression. But when I have a late deceleration, I am changing her position to get her weight off that maternal aorta and vena cava so that I can increase my placental perfusion. Keep in mind the reason for what you're doing. You don't just want to automatically do the same thing without knowing why you're doing it. Here's a picture of what a late deceleration would look like on a computer monitor. Remember, they're called lates because they return to baseline late after the contraction ends. Here we have a baseline of 150. We have contractions, 1, 2, about every 2 minutes apart. You can generalize. At the peak of this contraction, my fetal heart rate begins to decelerate, begins to go down. Think about your uterine placental perfusion. The contraction begins, it squeezes your baby, your umbilical cord, and your placenta. Remember the graph of what happens to our circulation to our fetus at the peak of the contraction. My baby runs out of oxygen here, for some reason does not seem to have a buffer or a reserve supply that's well established, so my fetal heart rate begins to go down. The contraction goes away, my fetal heart rate takes a little bit to adapt to that increased circulation, recovers, says, okay, I'm better, life is good again, but then that next contraction comes along, cuts off that oxygen supply. My baby says, nope, I'm not going to cope with that very well. My heart rate begins to go back down again. The end of my contraction happens. My baby recovers and says, okay, whoops, life is good, coming back up, until, as you can kind of see on the edge here, we have the same problem again. These are repetitive late decelerations because they're happening with every contraction. The more often they happen, the more concerned I am. Now, what's my variability? I still have moderate variability, so I know that I don't need to intervene to the point where I need to run back for an emergency and get that baby out right now, but I certainly need to put into place whatever I can to enhance my uterine perfusion. So I'm going to change your position. I'm going to turn off any medication that makes my contractions stronger. I'm going to put an oxygen mask on her. I might give her an IV bolus. And then I'm going to call my doc and say, hey, this is what we're seeing. What other ideas do you have, or would you like to come in and evaluate? Last of our decelerations is called a prolonged deceleration. This one, thank heavens, is nice and easy. A prolonged deceleration is simply any sudden decrease in the baby's heart rate that lasts longer than 2 minutes. So once you've seen that baby's heart rate descend below the baseline for a longer than 2-minute period, you know you're good to go. You can just say it's a prolonged deceleration. Why do prolonged decelerations happen? We don't really know. Sometimes they seem to be seen frequently in women who suddenly begin to have a fast labor. So if I have a prolonged deceleration, one of the first things I'm going to do is change my mom's position, because that will take care of cord compression. It will also increase my maternal perfusion. I might check her cervix just to make sure she's not suddenly dilating from 5 centimeters to 10 centimeters. This can happen when she's going through a really fast cervical change like that. I will also check her cervix to rule out a cord prolapse, which could be another reason why that baby's heart rate would go down for a longer period of time. Now remember, at what point do we call this a bradycardia? It takes a full 10 minutes for this to become a bradycardia. So anything between 2 minutes and 10 minutes is going to be a prolonged deceleration. And in this one, we can see 1 minute, 2 minutes, 3 minutes, 4 minutes, 5 minutes, and it looks like our baby's coming back up to baseline. So we have a 5-minute deceleration in which we're going to change her position, put her on her side, check her cervix. We might give her oxygen and an IV fluid bolus just because we know that's going to enhance perfusion of her placenta. And then we will give our doc a call. Hopefully, by the time the doc says, okay, I'm on my way in, our fetal heart rate will be back up to where we were before, and we will continue to watch and wait. What is reassuring to me on this slide? You guessed it, variability. I have a prolonged deceleration, but I also have moderate variability over here. So I know that my fetus still has a central nervous system that seems to be working well. If I had a prolonged deceleration with absent variability, I would be moving towards an emergent delivery. Let's talk about communication. When a hospital has what is termed a poor outcome, that can mean a fetal death, or it might just mean our baby was born There was some unexpected resuscitation that had to be done. All sorts of things are called poor outcomes for hospital legal departments. Any poor outcome that happens, what the hospital does is they get everybody together to sit down at a table and talk about it and say, hey, this happened. How can we keep this from happening again? When we did national studies that looked at lots and lots of discussions about poor outcomes, they found that the most common reason for poor outcomes was, you guessed it, poor communication between the provider and the nurses. We've had lots of terms that we've used in talking about this wide variety of decelerations, changes in baselines, different things and interventions that we can do. You can understand how, if you're waking your provider up at 2 in the morning and trying to describe something that you've seen on a screen, for them to be awake and alert and understand what you're saying is not always quite as likely to happen as we would want it to be. So in an effort to make communication more clear among team members, an amazing thing happened. I'm being a little bit sarcastic here, forgive me. The ACOG, Association or College of Obstetricians and Gynecologists, which is basically the obstetricians, and AWON, which is the Association of Women's Health Obstetrical and Neonatal Nurses, which is the governing organization for nurses. These two organizations actually came together and sat down and had a good long discussion. They hammered a lot of things out, and they decided that we need to use the same terminology so that we are clearly communicating with each other all the time. The National Institute of Child Health and Human Development helped out with this process, and how they decided to facilitate communication is to come up with 3 different categories. This simplifies things. Now, when I wake up my provider at 2 in the morning, I can say, I have a category 2 strip or a category 3 strip. No other words need to be said. We instantly know what we're talking about between each other. You do not need to memorize fine details about what makes what strip a category 1, 2, or 3. What I want you to know is that a category 1 strip means I have proof of normal acid-base status. This would be a lack of decelerations or early decelerations, because that's not hypoxia, so category 1 could include those, moderate variability, and I might have accelerations. All of those things are strongly predictive of the normal acid-base status. A category 2 strip is a little trickier, and this is what the majority of our concerning strips fall into. I don't have proof that everything is right, but I don't have definitive proof that anything is wrong. So what do? I continue to closely watch and continue to reevaluate. So if I have a strip with variable decelerations, or I have a strip with moderate variability, but late decelerations, it looks like I might have something wrong, but I also have signs that something is okay. So I'm going to continue to watch. A category 3 strip means I have proof of an abnormal fetal acid-base status. Really, the most common thing that we will see in category 3 is a absent variability. That is telling me something is abnormal, especially if it's combined with late or variable decelerations. If I tell a provider I have a category 3 strip, it is understood that I need them in the hospital right now, and I'm probably going to meet them in the operating room for emergency C-section. If I use category 1, 2, or 3, I can significantly improve communication among my healthcare team, which is going to benefit my patients significantly. I want you to keep an ear out in clinical for these terms, category 1, 2, and 3, and see how the nurses use them when they're communicating with the providers. I'm going to show you an example here of another category 3 strip that is very, very unusual. I'll tell you some stories in lecture. This is called a sinusoidal fetal heart rate pattern, and you're probably not going to see it in your clinical experience. I've only seen it twice in 15 plus years on the floor. A sinusoidal fetal heart rate pattern is a unique heart rate pattern that is suggestive and associated with fetal hemorrhage inside the uterus. We don't know exactly why, but if you look very closely, there is absent variability here. That might look a little confusing because you can look and say, hey, aren't those accelerations? Well, look at what they look like. It's a repetitive wavy pattern that is very, very smooth. So there's actually absent variability here. Sinusoidal patterns are category 3 strips because they require emergent delivery and very, very close attention very, very quickly. But you're very unlikely to see it as well. It is possible for a fetus to have something called a pseudo-sinusoidal fetal heart rate. Just to make your mouth wrap around that phrase, say pseudo-sinusoidal 3 times fast. This can be a similar heart rate pattern that is caused by a narcotic administration. For some reason, some narcotics will occasionally cause the fetal heart rate to go into something similar to this. It will have the same kind of undulating consistency. The difference will be when you look very closely, there will still be some variability and some wiggliness to those lines. If you hear the term pseudo-sinusoidal in your clinical rotation in labor and delivery, look at that strip very closely and you'll see the nurses looking at it as well, just to make sure.